Good morning, Louis.
Hello, John.
How you doing?
I'm here.
Okay. Uh, I'm just trying to get my camera set up myself.
That's okay. I take a coffee and come back.
Yeah, yeah,
I
we got time.
okay. Let's
We
turn
got
on my
10.
camera. I'm
Yeah,
here.
we got 10 minutes, Louis. So do what you need to
Okay,
do.
great.
Okay.
Okay, thank you.
Good morning, Nor.
Hi, good morning. How are you doing today?
It's great to see you.
So good to see you too. How are you doing?
I see you promote it more than me.
Really? Thank you. No, I'm trying to follow you and your guidelines. You are the pioneer. You are still the
Hey,
inspiration when it comes to promoting.
hey, where do you have do you have your picture with you? You, you're not showing your face.
Oh, yes, yes. It's my DP. It's my DP showing on on Zoom, not my video actually.
Oh, okay.
I took it on at Pins. This is Pins, the Punjab Institute of Neurosciences.
Oh,
I
okay.
took it, our book, we have just released this book, so I took this picture, I put it as my DP everywhere. So
You
it's here
walk,
as well.
do you walk around the streets of Pakistan with a book like that?
Almost like this.
Well, it
But
should
we
should be proud of it. You should be proud of it.
yeah, and thank you very much for promoting it as well on the website. I was so happy to see you. Thank you very, very much.
Yeah,
The
sure.
response
But
has been so tremendous.
well, it's because the you guys came out with three books, Ike, you, and Ted from Cornell,
Yeah,
at the same time. So I thought, what the heck, might as well make a post for
yeah.
all three. So,
Okay. Oh, that's great. It's so kind of you. It means a lot. I was so happy to see it, and the response has been so tremendous. The publisher has made it the featured book for their website on the publisher official website, and they have now requested me to provide a companion book for it as well. So I'm writing. I'm going to finish the flashcards and MCQs for this book, while they also want me to do more for this. And I'm also recording a video because the publisher wanted us to share a video of us showing our book and telling the important features, etc. So I've been trying to compile a video of my own. And I also received a recording from Professor Luis Borba. So I will be finishing the video today, and I will share that with you as well.
okay. When will that be done?
Thank you very, very much.
Oh, you
You
have
are
a lot of work. You have a lot of work, huh?
Yes, nowadays it has got me quite busy, as I'm also going to, join my fellowship in brain tumors in New York at Mount Sinai in just a little, just in a month
Are
or
you
a
gonna
month and a half.
travel there? You going to New York?
Yes, to start my fellowship in international brain tumor, as an international brain tumor fellow
Oh,
with
great.
Professor with Professor Isabel Germano at Mount Sinai in New York.
Oh, wow. Big hospital. Big hospital.
Yeah, thank
Big
you very
neuro,
much.
a big neurosurgery department. Huge.
Yeah, I've heard that too, and I'm very excited. I actually won the CNS International Observership Award. I'm supposed to, I will be receiving it during the CNS annual conference in Houston on 28th of September. They have a reception for young neurosurgeons, and it's a very beautiful venue. They have, a place which is in the shape of the map of Texas, where they will be organizing that wonderful reception. I'm so excited, and I believe that it will be really helpful for me to join this fellowship. And I will also request you to guide me further. And I'm so excited because I'm so happy that I'm joining with
Well,
her. And
of course, we'll plug you into Mount Sinai if you want to if you want to televise from there. And maybe organize something from the hospital for your other
it,
fellow.
it's in my mind. It's in my mind, and I will try. I will go and see how things work. And
Oh, that's an
it's
advantage
certainly
for you to have that ability amongst your other fellows because you're probably going to be the most agile on video platforms, which I think they may welcome that.
Yeah, exactly. It's very, I believe they are quite enthusiastic because I see their social media is quite active and they are all the time sharing many things like many webinars and etc. So I believe that there will be some sort of opportunity for me there to do some stuff like that, like you have said with other fellows. So I'm actually looking for it as well if I can. So it will be really, really nice. And I have, like you have mentioned, I've known that they do a lot of advanced kind of, they use a lot of advanced techniques, and they are also so much into the brain computer interface and etc. There are so many things there which are
Uh,
quite
Are you doing,
interesting.
is it oncology fellowship, observership you're doing?
Yes.
Oncology.
Yes, in oncology, in oncology. In Pakistan, we don't have any certain type of subspecialties, etc. There's nothing of this type, of
Right.
this kind. We are just general neurosurgeons, and I believe it will be very helpful for me when I get back to my country. So, and especially in neuro-oncology, there's I don't think there's anyone who is, and no neurosurgeon has been trained for neuro-oncology specifically. So sometimes it gets very weird because many people don't even know the newer concepts and even the new definition of glioblastoma, and it gets a little weird. So I think that it will be really fine to get back and start practicing on neuro-oncology and teaching people if that's possible. But and I believe it will be helpful.
Yeah. Well, that's next month you go?
Yes, I'm supposed to attend the CNS annual conference in Houston and followed by
Okay.
my joining.
No, no, it's Houston. It's not Houston.
Oh, yeah, Houston.
Houston, not
In Houston.
Houston.
Yeah, Houston. Yeah, thank you. Yes, in Houston. So I will be doing that, and after that I will join the Mount Sinai as a fellow. So that's it. It's
Do
like
they have dormitories you're going to stay at the hospital or something?
yeah, that's what I'm trying to find out myself.
Yeah.
I asked another fellow who's doing, her observership currently, and she was able to find a sublet inside the Mount Sinai Hospital, and I'm trying myself to find such an
Oh,
opportunity because it will be very good.
you don't want to be loose on the streets of New York looking for a place. You don't want to be
Yeah,
in that position. I'm sure there's a way that there's a way they provide. It's a big hospital, so I'm sure they have people visiting from all over the world.
yes, I'm trying to find if there's an opportunity there because this is what I really want to live inside the hospital. That will be much more easy for me, especially initially when I will go and join there. It's totally a new place for me. So I think that it will be really nice. Somebody said that there are trainees and others who are like going for some rotation or something like this, and they have their apartments, open for sublet. So I'm trying to find something like this. The fellow who is there right now told me that she is also living in an apartment. Again, it's a sublet. So I was asking if that opportunity remains till the date I joined myself. And she shared another apartment which is quite near. I think it is near the Central Park. So she shared me an apartment which was quite near, and she said that I can go on foot I can reach Mount Sinai on foot. But I'm still trying to find. Do you have any idea? Do you have anything that you would like to recommend regarding this,
Regarding what?
regarding accommodation inside the hospital or nearby?
Oh, no, just you have to check with administration and yeah, I'm sure they have ways that visiting professors and visiting people can stay on short term, like your friend did from I guess someone they knew, right?
Yeah, she's from Ethiopia. So she had someone from Ethiopia who was already in at Mount Sinai who was a medical student, and her friend was rotating somewhere else in some other city, I don't know where. So she had her apartment up for sublet. So she actually acquired that apartment as a sublet. So that's what I was thinking. Even if I find a sublet, it will be good for me to stay inside the hospital. So I can actually have a lot of, better opportunity of visiting all the time. And since I believe there will be some research work for me to do, that will make it easier for me to stay connected with the hospital and also, my room or my apartment. I will be able to do much better to stay connected inside. This will be very good.
Yeah, excuse me, I'm trying to get a hold of Ben here. Uh, oh, and I don't know what's going on here with Ben. Uh, well, I'm puzzled. I've reached out to Ben through uh, Instagram, so I'm just
Dr. Binzu?
yeah, I'm trying to hold Dr. Ben because my WeChat, I'm having problems with my WeChat account. Do you have a WeChat account, Nor?
No, I don't have. I don't use WeChat
I'm
actually.
just having
So
trouble with maintaining like it's important, but I can't.
yeah,
I changed phone numbers, and when that happens, it's a big deal once you establish an account with them. You got to kind of go through all kinds of hoops to get back in. And I can't get back in. That's how I used to communicate primarily with
yeah,
Dr. Ben. And he liked
yeah.
he liked it. He liked it. He answered
Yeah.
quick. But unfortunately now he's
I've heard that in China they use a lot of WeChat.
yeah, I'm sure if you deal with China, you gotta. I feel hindered. I feel weak
Yes.
whenever I try to get a hold of Ben because
Yeah.
oh, he's
Maybe he's
coming. Oh,
busy
good.
from.
He's coming. Yay. Lewis, I was sweating. Great. I just got a message. The
You
Giants,
received
the
it.
Giants. Lewis, are you there?
Yes, I'm here.
Yeah, I was getting
How
worried.
are you?
I thought, oh no, it's not going to come. He's coming. He's coming.
Okay.
Good morning,
Good
sir.
morning. Good
Good
So,
morning.
morning,
so
sir.
you have your co-author here, Noor.
Yeah, yeah.
Yes.
She's very happy.
Good morning, sir. Good morning,
Morning.
sir.
Morning.
She walks around the streets of Pakistan with that book.
Yeah, yeah. I know, I know.
It's now available in 180 bookstores and also in our institutional bookshops. So it's like it's quite famous, and even the publisher has made it their featured book. The response has been so tremendous. So I'm really so
It's good.
happy that people have responded. And the publisher now, requires us to send a video, which I will be finishing today, sir. I've just received your video, so I will be, giving it the finishing touches according to the publisher, and then we'll share with the publisher so that they can share it because it's a featured book by them. So they are very, very much excited, and they have asked me to submit the companion book, MCQs, and flashcards so they can publish it too. So I'm so excited. I'm trying to make things, draft the final companion book as well in the meantime.
That's interesting. Like as far as promoting publishing, Nor and maybe Lewis could answer. Do you push it to universities? They
Yeah.
put it in their bookstores. Is that part of the normal publishing publisher's duty to do that?
No, no, unless they, unless they have enough of the response. If they get enough response and they know that the book is worth it, they usually reduce the price so that everyone can, buy it because it's like an economical strategy that the number of, if they think that the number of buyers are more, then they reduce the price because they will have a lot of benefit from them. They don't give out to others, nowadays. So the more of the benefit is by the publisher himself. And if they think that they are receiving response, then only in that case they provide the book to the institutions as well as the institutional bookshops. So our book will be also provided to all the institutions that include universities as well as medical colleges and hospitals, and also to the head of all of these universities and the CEOs of all the hospitals, because they think that during the initial week they had a lot of response, and now the publisher has stepped forward and has taken another step to promote it to the institution level. So by now it is also available at AKUH, Aga Khan University. I hope you know about it, because it is considered the top university in the private sector. So it's also available at Aga Khan University Hospital Bookshop, as well as in at PINS, which is from where I belong, the Punjab Institute of Neurosciences, and all the other hospitals, institutional shops. And now I'm also crafting a letter for the CEOs, because the publisher requires me to write a letter to the CEOs as they are providing it to the CEOs and to the institutions, so that every of the head in Pakistan has a copy, and they also have a copy of our book in the official library. So yeah, it's a huge thing. It's basically an honor that the publisher gives only when they think the book is worth it and they have a lot of response.
Okay, Ben's trying. Let me get him the link. Okay, we're getting there. Okay, we're making progress. Sorry to keep you waiting, Lewis.
It's okay.
Just Ben just got the link.
The WeChat channel is on.
I'm sorry, Lewis.
The WeChat channel is on.
Yes, yes, it's live now. Actually, I turned it on live. We're speaking live right now on the internet before the broadcast. because I assumed it would go smooth, but that doesn't always happen, as you know.
Yeah, I know.
Just- So you just got back from India, right, Louis?
Yeah, I was in India.
You must be building up the miles.
Yeah,
Wow.
a lot of things.
Okay. Oh, okay. Mohammed. Oh, there's Ben. Okay. Good.
Hi, John. How are you doing?
Hey, Mohammed, how you doing? Would you like to introduce Ben?
Yeah, Professor Ben is coming now.
Yeah, he's coming in. And Mohammed, I'll introduce
Hello,
you.
John.
Yeah,
Hello.
okay. Hey, Ben, how
Hi.
you doing? I'm glad to see you.
Yeah, nice to see you again.
Okay.
I sent some message to you to your WeChat account, but you didn't reply.
Yeah,
Is it
I'm
okay
still
for
trying.
your account?
Yeah, I'm still trying to get that WeChat. It's not easy. Louis,
Uh,
are you there, Louis?
Yes, I'm here.
Yeah, okay.
Hello, Professor Shu.
Hello, Professor Luis. Nice to see you
Your
again.
first name is your last name is Shu or Bean?
Bing. My
Bean.
last name is Bing. She is my family name.
Shu is family name.
Yes, yes.
Okay.
Mm.
Okay.
Okay.
For you, Bean is like Luis.
Yes, yes.
Okay, okay.
Okay, we're gonna start, okay?
Okay.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 1. Good morning. This is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. We have the great honor of having the president of the World Federation of Neurosurgery, Louis Borba. And to introduce him, I'll have Ben Su, a famed neurosurgical educator from Shanghai, who's an expert on cerebral bypass. I'll introduce. Hello, Ben. It's good to see you. Oh, you muted there, Ben. Could could you introduce Louis, please, Ben?
Hello, John. Yeah, it's my great honor to introduce Professor Luis Boba, and he is the next president of WFNS, and he is also very famous neurosurgeon in the world, and he already visited more than I think it's more than 60 or 70 countries and made a lot of seminars all over the world. And he is a world famous neurosurgeon and very impressive work, great job for his teaching and for his clinical work. Thank you, Professor Luis Boba. Now,
Thank you.
please.
Thank you, Bean.
Yeah.
Thank you, Bean. Thank you for the opportunity to be here filming this Sunday. And we city now is 4 degrees centigrade. It's a little bit cold, but you go there after to run. Today is there to go to jogging, to go to the street. And we're ready to go now.
It's a winter.
Yeah, it's the
Okay.
end of the winter, but it's still cold.
Okay.
But yesterday was 25. Crazy. Today is 5. Yesterday was 25. This is the word today. I don't know. I'm trying to share my presentation here. Let's see. Can you see?
Yes, so it's not full screen yet. Okay.
Yes.
Yeah, perfect.
No, first screen.
Yes.
Okay, good. Okay. When I start to study skull base in the 90s, largest incision was the best surgeon. The approach starts on the top of the head, it goes to the bottom of the neck. And sometimes they're doing the approach, and to take the tumor was difficult because of the situation or the attachment, or the tumor was to adherence. And now we are going to a different route. In the 90s was 10 medical specialties participating in the surgical procedure. It was a little mess, but everybody wants to participate. Now we are coming to the era that is small, minimal. But always we start with one extreme, go to another extreme, and to find the point. Second. It's Harvey Cushing, more than 100 years, I think 100 years ago. Our goal is the cure. And the cure is try to remove the lesion and have the cure with neurological preservation. Today we're talking about control, but control is not cure. Cure is our goal as a doctor. When you do medicine to cure the people, or at least to try to cure the people, and that to do our best. There is nothing that is more satisfying to a neurosurgeon than to have a patient come to you with tetraparesis and not talk about approach, talk about and remove the tumor, and the tumor recover the deficit, and continue and do that. Nothing is more satisfying to have a patient 35 years old and come to you. This patient go to several hospitals, come to you now. The people say that it's impossible to remove this large tumor, just decompress. This patient comes with tracheostomy, gastrostomy, in the wheelchair. You do the surgery, you remove, and you find a plan. And this nice plan that you can go and take the tumor. And this guy can come back to his work and preserve all the nerves, all the structure, all the vascular structure. And the people come back to the work after time in the recovery and try to eat. This, as a doctor, is the great gratitude that you can get. Skull-based surgery you can do. You can go today to anywhere. You can go to the sphenoid sinus. You can dissect the cavernous sinus. You can go to the posterior fossa. You can reproduce everything that we learn in anatomy in the lab. But sometimes you need, sometimes you don't need. Today, the big change that we see is a deep understanding of anatomy, the microsurgical techniques, and the technology that is coming day a day and better. It's make the difference today. Because these today, more than maximal and minimal, we can go to the point. That is the place where you need to go. Today, the technology help you a lot. You can plan the approach. You don't need to do the approach to explore. You must do the approach directly that you need, in the size that you need, and the location that you need. You do the minimal, but with the maximal. This way you can get all the option, but you need to know all the routes to the cranium into the skull base. There is no more time in the world to train in the head of somebody. You cannot go to the OR to learn. You have to be prepared. You have to study before. You have to be ready to do the surgical procedure. Imagine if every airplane or the pilot will learn during the flight. What's happened? We crash one airplane every day or every hour. You cannot learn in the act. The skull-based course, the course that you do around the world, is excellent to open your mind. Does not mean that you go there and do a 2-3 days course and come back home and do the surgery the other day. This is the way that you can go, you learn, you understand, but you come back. You have to train, go to anatomy department, go to the lab and try to improve the technique that you just knew and understand. The problem is not the approach itself. This is one example, minimally invasive endonasal. Maybe good idea to can come here. It's a little bit down, but maybe okay. Okay? You can go and try to remove the tumor. And the guy did a course in US and came back home and did the surgery the other day. Was a big mess. But the problem was not the approach. The problem that the guy did the course and came to train in his own patient. You cannot do that. You cannot do that. In the literature today, there is no limit for any kind of craziness. It does not mean that any literature, anything that is coming, that is written, that the people's newspapers, everything is published, does not mean that is the best way. Imagine this paper just can come out. They try to remove a pituitary tumor, a small pituitary lesion, and maybe is not indicates to expose the ICA, but now they are exposing ICA to every case. I don't know why. Even in tumor that is limited to the midline. And they damage the ICA. And they create one technique that they say that advanced. Take the piece of the tongue. Imagine, piece of the tongue to close the hole in the ICA. This patient will have no words to say thank you, because imagine the pain you have in this tongue in the post-op. It's a new technique. It's a novel technique. Man, it's the literature. It's the literature. We need to understand that if you have the machine, does not mean that you need to use the machine to everything. I like to do surgery in the cavernous sinus. I know how you can do surgery in the cavernous sinus, but you need to understand the pathology that works, that doesn't work. Example here, hemangioma of the cavernous sinus. If you do gamma knife, the hemangioma disappear. Same thing happen with, you see, I like to do this case. It's possible to remove, possible to preserve the gland, it's possible to decompress off the nerve, but the gamma knife works for hemangioma. You see here trigeminal schwannoma, trigeminal schwannoma. You see, there is something here. Radiation does something. But I like to do surgery. You can decompress, you can remove totally the tumor, you can preserve the trigeminal nerve function. You don't have the complication that sometimes is common, anesthesia dolorosa. But you see that works. But look here, the majority of the tumor, the covenosinus, more than 60% are meningiomas. And you don't see any difference. Then why to treat this patient with radiation therapy? Because I have the machine, because I need to use, I need to pay, I need to do number. Why? Maybe the natural history is better than to treat with radiation for meningioma. Has to be critical in our decisions. After another decision, you go to the WNS and see this as a propaganda to radiation therapy. One of the easiest tumor in the posterior fossa. Look at the attachment of the tumor. Why to give radiation to this? And why to make a propaganda in the booth for this tumor? Why don't put a metastasis? Why want to put another thing? Do you know why? The meningioma is one of the most common tumors. Here we are talking about business. We are not talking about medicine. More than that, we are seeing now people advocating radiosurgery for aneurysm. This is experimental. Journal Neuroscience Rural Practice. And somebody in the world, unfortunately in my country, is offering radiation therapy for some kinds of aneurysm. Believe it or not, it's true. We are coming to the anterior fossa. During many, many years, you learn to do the Piterno approach. During many, many years, you learn to do microsurgical technique, to improve the microsurgical technique. Now it's come a new idea that to remove the tumor from the nose. Maybe good idea. For a small tumor located in the midline. Maybe good idea. But let me tell you, what's wrong with microsurgical technique? When you go and dissect and open the Sylvan fissure and separate all the structure, proximal control, you can see the tumor here. You can dissect. Or you prefer to go down through the nose, pull the tumor and pray. Because the last thing that you see are these vessels here. This vessel will be in the back. If you remove and pull the tumor, maybe the vessels coming together, attached to the tumor. And it will be a catastrophe. And what's going on here? Very simple tumor. You see here some more details. Dissect the arachnoid, dissect the optic nerve, identify the tumor, dissect the olfactory nerves. Short instrument, stable hands. We do this, we learn this in our entire life. Why now you are changing? Why now you are going to come to the nose and destroy everything in the nose? Because it's new? It's good? I don't know. We need to learn that the best way to reach anything in the brain, in the skull base, in the cranium, use the natural roots. And the best root are the fissures, the cisterns, that you remove CSF and you identify the structure. identify the nerve, just follow the roots. Imagine if you go to Veneza in Italy and try to reach everywhere through the buildings, not through the channels. We need to use the channels. The channels will give the root to you. More new techniques, modern. The tumor, why to do that? Why come from the nose, destroy completely the nose, and just bite the tumor? And after do the transcranial approach to remove the tumor. What's it? It's medicine or it's business? To surgery, charge twice. We are not talking about patient, we're not going to talk about medicine, we are talking about business. Cannot be like that. Cannot be like that. What's wrong here? The tumor is coming down here, see in the frontal area. You open the door, you see the tumor. And you go to the base, remove the tumor, remove the bone, and feel the sinus. And the advantage that you are coming from up, that the anterior wall of the sigmoid, the sphenoid sinus is there, you can pack the sinus full of fat. You will not have CSF leak. The endoscopic view is unbeatable. You can see structure that you never imagined that you can see. But you need to use with criteria that the really case that you really need, and the really case that is better than the other one. Not change, just change because you want to change. Has to change because it's better. See, for pituitary tumor, you see, is a lot advantage. For craniopharyngioma, is a lot advantage. For chordoma, there is a lot of them advantage. And maybe a small, very small meningioma, I'm not sure. Maybe not, probably not. But you can come from the nose with the microscope, with the endoscope, and do the dissection of the cavernous sinus. But what gave you the approach here? Here's the ICA, here's the lateral wall of the cavernous sinus. Who gave the approach? Who gave the approach was the tumor. We are just following the tumor. We are just following the money. See? And you can go and use the endoscope to see all the corner. That is very, very, very useful technique and instrument. For craniopharyngioma, you can do the same. If you have a tumor like this, you have a root that's coming from the sphenoid sinus and just follow it. You can go, can identify the cella, can open the cella. In this case, I combine microsurgery and endoscope. You go to remove. At the end, you have this view. This view with the endoscope. You can check and see everything. This you never see with the microscope. This with the endoscope give you this wonderful, wonderful view. This is a great advantage of endoscopic surgery. You can see everything that you never imagined that you could see. You can go, if you can close, and can have a good post-op CT. Pituitary is the same. You can do the same with pituitary lesion. You can go, drill, remove the tumor of the endoscope, and do that. Let's change a little bit about surgical position. We are seeing now in the books, say, oh, posterior communicate aneurysm 34 degrees to the right. Anterior communicate 45 degrees to the left. Carotid artery 15 degrees. Man, you have a compass in your head? Of course not. The trick of the surgical position is to keep the bilateral internal jugular vein open to allow the flow. And this is easier to control the intracranial pressure and release the veins. And if you need to rotate to have more angle, you can use the table. I don't see the people talk about the table. See, to mobilize the table to right side, to left side, up and down, elevate the dorsum, elevate the back. You can do this. More than they change the position of the head. Professor Yashagiro using always 30 degrees and rotating the table and mobilize the table. It's make the difference. And you have the open view. You see, it's open to drain the internal jugular vein. It's very, very important to be sure that the contralateral internal jugular vein is not closed. There is area today that you understand more than in the beginning. When Professor Vink Dolenk opened this box, he showed to everyone that it was possible to do the surgery. But today you need to have a critical view. What's possible, what's not possible, what you really need, what you really don't need. But more than know how to do it, we need to know the natural history of the disease. Cavernous sinus meningioma, 78%, the diplopia regress the symptoms with just corticosteroids. And just wait and see. I'm talking about the small cavernous sinus meningioma inside the cavernous sinus, not the one that is large going outside or coming from outside to inside. It's completely different. I'm talking about the small one that the patient had a slight diplopia. 90%, you never come back in 10 years or have very slight. 90% increase, 71% is stable, almost 10% decrease without any kind of treatment. Wait and see in the majority of the asymptomatic or oligosymptomatic, small cavernous sinus meningioma is the best treatment. Wait and see. The Dolenk approach is no more than a difference, an extension of the classical pterygium approach. You don't need to do more that to remove the anterior clinoid, to remove the thing, is the extension of the pterygium approach. The anterior clinoid, that is the trick to expose the area around the ophthalmic artery and the ICA, have several techniques. And you learn, and for each case is different. For aneurysm, you need to do intradural. For tumor, it's better to go extradural, because you go extradural, you cut, you remove the bone, you do the peeling of the middle fossa, the dura, and you cut out the vascularization of the tumor. You cut the blood supply. And this way, you can improve your technique. You can remove the entire, the clinoid, or in piece. I prefer to drill in piece slowly and leave as a whole shell, and after do that. For aneurysm, go intradural and remove the amount of bone that you need. Don't need to do more radical. Some tumors in the cavernous sinus look like that. And you don't need to open the dura. You just go extradural. This tumor here is located here between V1 and V2. And you see here, you are just doing the peeling of the middle fossa. Just separating the dura. The tumor is coming out. It was a schwannoma of the parasympathetic branch. A very small tumor that was located in this area here. It can come and dissect and clean and decompress and working inside. And this you can get out the tumor and get a nice removal like this. And we preserve of the mobility. And the pre and post-op, you see that it's very clean, the MRI. When you do a simple case like this, you need to understand not only to remove the tumor, you need to understand the disease. If you want to have a control of long-term, with meningioma independent of the location, we need to remove the dura. And this is the point. You see this lake here, this venous lake? This part is the part where the tumor will, in the future, invade the cavernous sinus. Because this, we need to remove the dura, remove all this part here, and clean totally this part. Not only remove the tumor, but also remove the dura. That is the main attachment. See, 90% of the recurrence is less than 1 centimeter of the main tumor bed. See, you can go and can clean, you can remove, and you remove the dura independent of the area. This we need to do in every tumor that you can. Of course, you cannot do in everyone, but at least we need to try and get maximum dura that can get. Another situation like that, tumor is coming in the bone, tumor is coming in the dura. You need to go and need to drill the bone and remove the tumor. And at the end, the posterior part of the cavernous sinus you can clean. It's the fourth nerve, here's the third nerve, here's the fifth nerve, and there is a part that I left in the superior orbital fissure that you see here in this here, there is a small piece here in the superior orbital fissure attached to the ICA, attached to the nerve. Leave this part. Leave this small remaining tumor and wait. If start to grow, if the patient has some symptoms, maybe you can give radiation therapy. Sometimes the growth is so small that it doesn't change anything to the patient. Doesn't change the symptom, doesn't change anything. Wait and see. Maybe this lady and this patient will live forever with this remnant of meningioma. Now one area you call petroclival. There is more petroclival in the literature than real cases. Don't know why? You don't know why the people say they don't need to use the temporal bone, anterior petrosal, posterior petrosal. Why they don't need? Because 85% of the meningioma of the posterior fossa are not petroclival. Petroclival is 10 to 15%. This is not petroclival in the corner here on the left. This is not petroclival in the right here. This is petroclival meningioma. See, attachment the clival, attaching the petrous bone. See, these are the real petroclival meningioma. In the literature we are seeing today, don't need, because they are not real petroclival. We need to trust the people. We need to trust the people. If this guy has 1,500 meningioma of the area, and in a 50% he use, the petrous bone, it means that the petrous bone and the temporal bone we need to learn, and we need to use. Every case? No. Just the case that you need. The retrosigmoid, yeah, our workhorse. You can expose and in many areas We can come in the superior part, inferior part, the middle. The retrosig is one of the best approach in the skull base. I always say that in 80% of the case in the skull base, you can remove by paternal approach and its variation, and retrosigmoid approach and its variation. It's make in more than 80% of the case, 80. This one example. Oh, petrocleidomeningioma. No, the attachment is down here. You just follow here, retrosig, and you see that the attachment of the tumor is just over the vertebral artery. See, lower cranial nerves, the attachment is here. 7 and 8 are up. Lower here, the tumor is here. See, here's the 12, the vertebral, the lower cranial nerve. The main attachment is here. Your approach must be concentrated in the main attachment of the tumor, not the extension of the tumor. The main attachment of the tumor. This main attachment has to be in the field. Another situation, this petroclive, there is this part here in the clivus. Retrosig, it's very difficult to get this part inside the canal by other kind of approach. This angle here is easier by retrosigmoid approach. You can come directly and open the canal and remove this part that was inside the canal. Sometimes you need this approach, the posterior petrosa approach. I call this approach diversity. Why diversity? You have every kind of approach. You can use retrosigmoid, you can use presigmoid, you can use transtentorial, you can use subtemporal approach. You decide the angle that you want to attack. Because this, we need to know how to do the petrosa approach. You need in every tumor of the posterior fossa? No. You need in every meningioma of the CP angle? No. But you need for petrocleidomeningioma. In one example, large tumor, straight lateral. You see the tumor anterior to it. Sometimes you can use retro, sometimes you can use petro, you decide. Sometimes you need one and another one. This is one example, tumor in the posterior fossa and also tumor in the Meckel's cave. This is not cavernosinus, it is Meckel's cave. You can remove this part. You can come here and follow the tumor from the posterior fossa to the middle fossa. And see, you can use presigmoid, retrosigmoid. You see the lower cranial nerves? You see here in the fifth nerve from the posterior fossa to the middle fossa. Totally liberate in the fourth nerve there. There is no competition. You need to be prepared. Sometimes you need to extend, sometimes not. This is the post-op. This is the lady in the post-op preservation of the function. To end, let's go to this area, the foramen magnum meningioma. As another area have more approaches than the tumors. In the majority of the case, you don't need the total transcondylar approach, but you need to know how to do it. See, this is the classification, can be anterior, lateral, posterior, anterolateral, posterolateral, in the extension, up and down. And your surgical approach must be planned related to these extensions, into this attachment. If the attachment is more anterior, we need to go a little bit more lateral. If it's posterolateral, you can come posterior. If it's posterior, you come just from the posterior part. The craniosacral junction they define is from lower cranial nerves to the superior part of C1 or C2, but it's very large, very long area and are completely different when the tumor arises here and the tumor arises down. It's completely different. And you need to tailor the approach for each case. You tailor the approach for the patient, for the tumor that needs. You cannot have your approach. It's the approach that the patients need. For example, these two tumors. Look that. In the spinal cord, cervical, here, close to the foramen magnum. The foramen magnum. Oh, here is very difficult. Oh, here is very simple. Everyone can do that. No, this you need to be skull-based surgeon. It's different. What's the difference? The anatomy. Here is different than this. You know why? We are not used to this anatomy in the cranioception junction. If you go to the lab, you'll be very familiar with this anatomy. If you don't go to the lab, you're not familiar, and the surgery will be difficult to you. In the spinal cord, we are brave. We know how to do it. Everybody knows how to do it. But here it's complicated. It's not complicated. It means that you are not prepared. You are not prepared because you didn't train. Does not mean that you are good or bad. You didn't train enough. If you go to the lab and you train, you can do whatever you want. The symptoms of the tumoral cranioception junction are different. When the tumor comes up to down, it's different than going down to up. When it's up to down, the patient has lower cranial nerve deficit. When the tumor comes down to up, the patient has tetraparesis, has no lower cranial nerve deficit. It's different kind of tumor. This is another example that you understand the anatomy. In this situation, totally anterior, I need to come transcondylar. But look at that. Look at the size of the foramen magnum. Look at the size, the distance between the lateral mass of C1 was very wide, very large. The anatomy gave the approach to you. What's happened? A simple lateral open laminectomy of C1, open the foramen magnum, and you have the view. The tumor is coming out. The tumor is coming out alone because the anatomy gave the approach to you. It's not your approach. The anatomy of the patient makes the difference. Situation like this, you can do the surgery, you need to expose, but you can remove the tumor in one mass. And the vertebral artery, if you know the anatomy, you can mobilize the vertebral artery. You can remove all the attachment of the tumor. You can remove the dura in the anterior border of the foramen magnum. You expose everything. If you look at the vertebral artery here, it's totally free. You mobilize middle, lateral, superior. See, this approach was good. Neat? Maybe yes, maybe not. But mobilizing the vertebral artery makes the difference. But in this situation, I like to end with some words about neurosurgery. The neurosurgeon needs to have an open mind. The neurosurgeon needs to make judgment. The neurosurgery and the neurosurgeon need to take risk. In our specialty, you take risk in every case. If you want to progress, if you want to improve, you need to take risk. If you don't take risk, you don't go to anywhere. I think take risk is one of the points that you want to be a good neurosurgeon. You need a mentorship. You need somebody that help you, somebody that could be your role model, the guy that you trust, that guy that gives you the opportunity. You need to define priorities. Priorities, neurosurgery has to be one of your priorities. You need partnership. You cannot do everything alone. You need to discuss the case, to see to watch and to understand the contradictory is very, very important. You learn with everyone. Nobody is so good that everything is perfect. And nobody is so bad that everything is terrible. Everyone has one thing that's good. Everyone has one thing that's bad. You need to learn. You need to be happy. Happy what you do. Neurosurgery has to be part of your life. When you go to the OR and stay 10 hours, 15 hours, it means it is good. It is bad for you. It's problem to you to stay 10 hours in the OR doing surgery. Change your job. Go to another job. You will not be happy. And your patient also will not be happy. The OR has to be the extension of your house. The patient, the place where you be happy and try to do your best. And you need to study. Now we have a new book with Maria that is coming out now, Neurosurgical Approach, from the basics. From the basics. You need to know from the basics, step by step. And learning, and you go slowly building your own garden. One rose in each garden. You take one rose in one place, one rose in another way. You build your own garden. You build your own future. The laboratory is the trick. Go to train in the laboratory is the trick, but it's not only the beauty. It has to be there. Look at this lab here, my lab in Curitiba. It's very nice lab, you see? Very nice facility. What's the problem here? It's empty. The resident is so busy doing something. They don't have time to go there. Everyone has time. You need to make the time. Why this guy has time and the other guy don't have time? Do you think that this guy will be different? Will be the same like the other ones? Of course not. He's dedicated 24 hours. The time he can go to the lab. He's in the OR, he's in the lab, he's in the OR, he's in the lab. He will be completely different than the other ones. The other ones, maybe the future will not so bright. But dedication, focus, determination, and consistency is very, very important to plan your future and your life. Commitment and be happy. This is a case, just to remind you what is life. This is a case I did into me of our friend Sufyanov in 2014. A large petroclival meningioma. We went to the lab, we trained the approach, we went to the surgery, we did the case, 10 hours surgery, and after we are happy. We are having a dinner with the government, the CT post-op is perfect, and we are all happy. We did the job, the patient is okay. Now it's time to enjoy the life. Thank you very much for all of you, and sorry for the long time. Thank you, John. Thank you, Ben, for the opportunity to talk to you.
Thank you, Professor Luis Borba, and very informative and fantastic presentation. And you talk about not only the fantastic clinic case, but also the philosophy of the your neurosurgery philosophy is very fascinating and very amazing. But now, just like you mentioned, maybe few young neurosurgeons would be so dedicated. So, as the president of the WFNS, do you have some resolution?
You help me a lot. I need you. I need a guy like you. I need a guy that like you that go around the world to teaching and try to helping the people doing surgery, doing dissection, going to the lab. You wait till here in Brazil, November, to show us more and more. We need guy like you that go around the world and give the inspiration for the new generation. The microsurgery is not dead. The microsurgery is alive and more and more and more. And the World Federation need to do this job, to go to the young generation, to the medical students, to the residents, and show the value of the neurosurgery, and to be proud to be a neurosurgeon, one of the things. And you need to be critical. The people say that, oh, neurosurgery is dying. No, it's not dying. Neurosurgery is changing in some areas, but it's not totally changed. We are seeing new technologies that are coming, new approaches that are coming. Some of them are good, some of them are not. But the microsurgery is still there. The other day I saw a comment about the clipping arteries. Oh, clipping is dead, clipping is dead. Clipping is 45 years in the road, 45 years, and it's still alive. The endovascular is unbelievable what's doing today. It's growing better and better every day. But it still is not the solution. It's still not the solution. We are seeing case. I don't know why the technology is changing. It means that the anterior one was not good. And the clip is 45 years. It's still the same. Maybe you change a little bit. What's happened today is the microsurgical techniques. See, the results are going better and better and better. But you need to train. You need to prepare. What's the difference? In the past, we are learning with somebody in the head of somebody. How to learn to clip arteries, to dissect the vessel in the past. In the head of somebody. You go there and try to learn. Now it's different. Now it's different. Now you need to be prepared to train. When you go to the OR, you know you have the skill already. Of course, in surgery, there is the emotion, there is the acknowledgement. It's not the same. Oh, I'm not saying that you need to do a neurosurgery just from the lab. See, we need to go to the OR, do surgery, prepare yourself, but before, we need to train. Because we are going around the world. I was in India last week, 2 weeks ago, and I was in Karad with Professor Shirian. Man, he has a very nice lab. And the people to train, to prepare, now he's receiving people from around the world. I'm sure that in China, you have a lot of fellows that's coming from around the world to learn. And these people, when they come back, they will be completely different. They are completely different. And this training is the difference. And the World Federation must do that. Must stop fighting for these crazy things. We need to concentrate in educate the new generation that is coming. If you don't do that, a lot of problems coming in the future. Who miss? The patients. See? We need to do that. And you are the most important guy. I need your help.
Thank you.
And John Bennett did a lot. You see? When John Bennett started many years ago with Ebinar, before pandemic, when he started that, the people say, no, what you stay there 1 hour? Nobody will stay 1 hour in front of the TV. In the pandemic change.
Yeah, you guys make me feel like going into neurosurgery. Maybe it's not too late.
No. The pandemic was the worst time. It was the worst time in our lives, maybe. But for neurosurgery, was one of the best because it gave the opportunity to see the people around the world. You used to see Professor Binshu 10 minutes lecture. Fast, and the clock go. Now, Professor Binshu stay 1 hour showing all the tricks, all the techniques with calm, with time, and you can learn. You can go now to YouTube and ask for the lecture of Professor Spetzler. You find there 1 hour lecture, and you learn a lot. This is the pandemic. Pandemic time make this different to us. But now it's time to go to the field, to go to the people, stimulate, inspire the people. We need the neurosurgeon that really are neurosurgeons and believe and like and love what they do. You cannot live in many countries. I'm saying something. In many countries around the world, leaders countries, see, the money, the business is in front of the patient. You cannot do that. You cannot accept that. See, I don't know if you are recording this, but this should be recorded. Okay.
Hey,
Sorry.
Harshad, do you have any comments or questions?
Hello, Professor Luis.
How are you? Good to see
I'm
you.
fine. How are you? I missed you
Fine.
this time in Karat to see you, and I heard you online. And again, thanks
Yeah.
to John, who relayed your all programs, and I was listening to you. It is always a treat to listen to you, and always an educative format you give. What one should not do in neurosurgery, and one should do the neurosurgery, how you should approach. And this is I've heard you many times, and I agree with you that this pandemic has given a new life to a neurosurgeons. We have relearned the neurosurgeon. Absolutely correct, and we have to learn and learn. And like I heard Professor Binzu maybe more than 25, 50 times now, and seen his lectures and seen his work of that. And this is a webinar which is giving us an opportunity to learn more and more. And learning is something very, very important. I will tell you my experience when I joined 1985 neurosurgery. At that time, we didn't have even a CT scan, and we used to do percutaneous carotid angiography, and we used to do exploratory burr in emergency and all sorts of things. And slowly the CT came, MRI came. The aim was at that time is to save the life. If you have saved the life, you achieved something. As the time has evolved, the technology has evolved, we don't have to give morbidity to the patient. Whatever, this is what I learned. And as the time further evolved, more technology came, more experts have taught us. And we learned that the patient has to improve in the symptomatology. Patient has to improve in the morbidity. And this is what is a progressive learning. In my own experience, I've learned it's not only the saving the life, it is also to improve the functional utility of the patient himself. They should go back to the work. And best you have shown where not to venture, where you should not be very aggressive in that and give a deficit to the patient and make the patient miserable. This is one thing which we have learned from all of you, where one should not live. Everything can be excised, but what happens to the result? You have to give a result to the patient. And when I saw first time Professor Yasagil in Zurich, and I saw his techniques of dissecting the arteries, was one of the most wonderful thing which we have never seen. And he has taught us how to dissect an aneurysm, how to clip an aneurysm. And aneurysm clipping is not going to die irrespective of whether you do endovascular or do anything. Yes, we have to train ourselves as well as the younger people coming in, and something wonderful to learn from all of you. You are all doing great jobs to teach us and making us more wiser to do. Wonderful job.
Thank you.
And just now, the Professor Binzu has got some 30, 40 neurosurgeons waiting to get trained under him in China, which is something unique for doing bypass surgery. So things are much, much more, what we were trained in 85 and what the young neurosurgeons are now getting trained is very different, very different. And they've got a lot of technology, a lot of advancements, and a lot of this laboratory trainings. I could see pictures of your lab, super pictures to train yourself. And as we call in India, the OR is an extension of your house, as you said, but I call that as a temple. As you go in temple, how you pray, you work in OR. OR is something really wonderful. So wonderful techniques, keep it up, and WFNS is doing well, and I'm sure your presidentship will give more insight for learning to all of us, not only to juniors, but to seniors also.
Very good.
Yes.
Thank you, Harshad.
Thank you, Professor.
And we have a
I see here, Professor Gabriel. How are you, Gabriel?
Okay.
Just saw your question about the models. They are improving a lot. Still now, the best way is the cadaver. Today, still now. But the model are improving. And the great facility that you can do it everywhere. See? You can do it. You see now these upsurgeons. They are doing preparing cervical disc, endoscopic surgery. I think it's very, very not so similar until now, but I think it's improving a lot. It's not easy to get cadaver. The cadaver in the majority of the country is not permitted to get the head, to go see, but it's expensive also. I think the model will be the future. But to replace cadaver, I'm not sure now, up to now. Maybe in the future it will be different. No? What's important is to keep going, no? Keep learning, keep training, this is and the consistency and the commitment and the focus. If you do that, you go. See, I always show the football players. There are football players like Pelé, like Maradona, that the talent gave by God. And there is football player like Cristiano Ronaldo that is commitment, is training, is dedication, is focus. Everyone can be Cristiano Ronaldo. I think nobody can be Pelé. but this, everyone can do. Depend of you. Yeah? Okay.
Okay, very good. Thank you very much, Louis. And thanks everyone for participating. Ben, thank you for coming and spending the time. Harshad, Gabriel,
and
everyone.
Ben, how can I access the WeChat channel to watch in the WeChat channel later?
Yes, I this time, because we didn't prepare because we couldn't connect with John on the WeChat, so we don't arrange the broadcast in WeChat.
Well, you know I'll do, Ben. I'll send them the links to
yeah.
Brand
But after this real-time presentation, we will get the video from John and we will put on the WeChat channel.
Great.
So don't worry.
Okay.
Great.
Okay. Thank you.
Thank you. Have a good day, everybody.
Thank you.
Bye. Thanks.
Bye.
Bye.
Thanks, Ben.
Gabriel.
Thank you very much from
Ciao.
Colombia.
Thanks,
Thank
Borba.
you.
Ciao.